Good afternoon, and thank you for joining us for today's webinar. Our webinar today is on meaningful use, what you need to know. All of the issues and information you need to know about objectives for 2014. Today our presenter is Deanne McCollin, and she is from CalHIPSO in Oakland, California. My name is Rachel Logan, the Training and Technical Assistance Manager at the National Center for Health and Public Housing. This is some additional information about us and who we are. We serve health center programs across the United States, but specifically public housing primary care health centers that serve residents of public housing. Just some background information about regional extension centers and health center programs. About 83% of health centers and lookalikes use regional extension centers to get their training and technical assistance needs met. Overall, RECs or RECs serve about 18,000 providers across the United States at health centers and at lookalike facilities. A brief bio about Deanne before I pass the webinar over to her. Deanne is the Regional Extension Center Director of Meaningful Use at CalHIPSO in Oakland, California. She joined CalHIPSO in October 2012, where she began instrumenting and driving the performance of federally funded program, EHR incentive program that has helped over 4,500 providers achieve meaningful use in California. Deanne is responsible for the management of CalHIPSO's statewide network of local extension centers and service partners, providing education and research. Additionally, Deanne has become a subject matter expert on meaningful use and collaborates closely with CalHIPSO's member organizations, CMA, CPCA, and CDPH. I would like to remind all attendees that the webinar will be sent out following this webinar presentation, as well as being posted to our website at www.nchph.org. I'll go ahead and pass the webinar over to Deanne. Thank you.
Hi there. Thanks, Rachel. Welcome, everybody. I want to start this afternoon mentioning that if I happen to say Medi-Cal, that's just a little slip. I say that probably 100 times a day, and it's applicable to the Medicaid EHR program. There's both the Medicare and the Medicaid EHR programs, and sometimes I might reference Medi-Cal instead of Medicaid. Thanks for joining us today. I know everyone is busy, and 2014 is a big year in health information technology. Of course, the clinical day-to-day continues, and we want to make sure that we're seeing patients, and hopefully all of this feeds to delivering better clinical outcomes. We've been spending the last couple of years on stage 1 of meaningful use, and that has been getting everyone into the groove and doing data capture. As we advance in 2014, a lot of the eligible professionals are ready for stage 2. Not everyone, and that's one of the things I work a lot on, not losing sight that 2014 still has a lot of eligible professionals in, excuse me, in their first or second year of stage 1. Sorry about that. I will sip. Good old winter time. And stage 3 is on the horizon. There has been an announcement in December that there's a proposed extension of the initiation of stage 3, that it will not start until 2017, but it is still coming, and we all want to be looking towards that. So meaningful use is hoping to provide better clinical outcomes, improve population health outcomes, increase transparency and efficiency in healthcare, empower individuals, both the clinicians and the patients, and provide robust research data on our health system. Stage 2 final rule is has a couple different effects to it. 2014 is the first year that anyone can attest to stage 2. That's where the timeline was changed. There are some providers who were able to benefit and have 3 years of stage 1 if they were early attesters in 2011. Stage 2 final rule did make changes to stage 1, and some of those changes are different between Stage 1 folks who were attesting to 2013 and Stage 1 folks who are looking at 2014. We're also in a tail period where right now, January and February of 2014, people can be working on 2014, Stage 1 or 2, and also working on their attestation for 2013 program year. And the Medicaid programs have different deadlines. Many of them are March 31st, a month longer than the Medicare attestation. But there's changes to Stage 1, and those changes are different, which I'll go into some detail later. One of the significant changes with Stage 2 between Stage 1 are that there are increased percentages to meet many of the objectives. So something previously might have been 30%, now you have to hit 50%. Another one is an decreased timing. Clinical summaries, for example, you used to have to provide the clinical summary within 3 business days of an office visit. Stage 2, it's within 1 business day. So there's some changes, and those are some of the details folks who have been focused on Stage 1 for a couple of years need to make sure they are aware of those changes. Stage 2 combines certain measures, and there's a slide later on that gives an example of that, where you might be like, where did my core measure for recording medication allergies or the medication list is combined into another measure in Stage 2. And Stage 2, one of the biggest changes is that it gets into health information exchange and the use of patient portals. And clinical quality measures, there are different ones, and it's for 2014. So whether you're in Stage 1 or Stage 2, in this calendar year of 2014, you have different clinical quality measures that we refer to as CQMs to report for meeting meaningful use. So I'm going to talk about the timing of Stage 1 and Stage 2, and a little bit touching on Stage 3 with December's ruling. In 2014, there was a special ruling that came as a result of the Stage 2 final rule that every eligible professional attesting, regardless as to their stage, will report for 90 days, a 90-day reporting period in 2014. So if you just completed meeting meaningful use in 2013 for a full year, you can breathe a little easier in this year, 2014, for that reporting period. It's only 90 days. There's a lot of other compelling reasons that we need that extra breath, and that's for adopting 2014 certified EHR technology, later in the year meeting ICD-10. There's a lot of things happening this year, so that's one of the reasons why they gave a little bit of relief, that it's a 90-day reporting period. Something to think about with this 90-day reporting period is that if you attest to the Medicare EHR incentive program, and you have previously attested you were a meaningful user in 2011 through 2013, any one of those 3 years, then your attestation in 2014 must be fixed to a calendar quarter. That means you really only have 4 opportunities, 4 reporting periods to meet the measures. That is not applicable in the Medicaid programs. They all should be any 90 days. You do want to check with your own state's Medicaid program to make certain that their 2014 90 days is not required to be fixed to a calendar quarter. And for the folks that will have to attest to fix to a quarter, you want to be thinking about that. It's already near the middle of January, which is fairly amazing. But if you were looking at the first 90 days or the first calendar quarter of this year, there's certain things that you need to have enabled and have some sort of documentation of for your reporting period, such as drug interaction and drug formularies and clinical decision support rules. You need to be able to show not necessarily when you do your attestation, but you need to have the documentation if you're called for an audit in the EHR program, that these were enabled during the entire reporting period. So if you're looking for the first quarter 2014, You want to try to get back to January 1st or 2nd. I say 2nd for the first business day typically, and check with your IT or check with your EHR vendor if they have something that can show that your drug interaction and your drug formularies, your clinical decision support rules were enabled and turned on the first week of this year. You might also be able to bridge that if you had it turned on and have print screens from the end of December and then print screens today, tomorrow, that shows it's on. Your EHR might also have an audit log that shows that they were not disabled anytime during this year. So that's something you want to look forward to. But the main point of this slide is that it's 90 days for anyone, regardless as to stage, in 2014 for attestation reporting periods. This is a timeline. It originated with the CMS. You will see that if folks started attestations in 2012 in the Medicare program, they will now have 2016 as stage 2, according to December's proposal to move stage 3 out to 2017. The differences with the 1A and 1B are the changes to stage 1 as a result of stage 2 and variant based upon the calendar years. And again, we are making these slides available. If you have questions for looking for these slides, they will be shared with everyone. This slide, I apologize, I missed updating the under 2016. Wait, let me think through this. Maybe I caught it. 2016, yes, it's correct. In 2011, it has stage 2, and that would be someone's 3rd year. And this is for the Medicaid programs. Folks, eligible professionals are allowed to skip years under the Medicaid program. So this timeline scenario is when an eligible professional is progressing through their 6 years of participation in the program without skipping a program. So you are allowed to skip a year if you, for a business reason, perhaps your clinical hours, something unique in that year. Under the Medicaid program, you can skip, perhaps you went on sabbatical. Whereas under the Medicare program, once you start your 5 years in that program, the clock starts and your program years are sequential. And you might fail or miss a year, but you're not allowed to skip, and it progresses on to the next program year and the next stage that you would have been in if you're in the Medicare EHR incentive program. This link is a great little widget on the CMS website, and it's for whether you're participating in Medicaid or Medicare. And you click on it. It's still based on the eligible professionals, not by the group of doctors at your practice or in your organization. But it's a fun little widget that clicks along to show the different scenarios for what stage you're in. And a lot of folks, as each year is moving on, are going to have a lot of different doctors and eligible professionals to manage at different various stages. You'll have some doing the AIU under the Medicaid program, some doing stage 1, some doing stage 2. You're allowed, as if you're an organization that's managing multiple eligible professionals in the EHR program, you're allowed to have some of them in the Medicare program because maybe they didn't meet the Medicaid 30% encounter requirement of the program, or vice versa. If a doctor did not have enough Medicare claims that it was more beneficial to participate in the Medicaid, you can have doctors in different stages, AIU, stage 1, stage 2, and in different programs, Medicaid and Medicare. So there's definitely a lot to manage, and this is just one small tool that might help you with some of that. There is the timeline that shows what the incentive, the eligible amounts are. The maximum eligible in the Medicare program is $44,000. That is actually subject to sequestration. So there's a 2% reduction on those Medicare numbers. The Medicaid program does not have that reduction amount. The first year of Medicaid, you are allowed to do meaningful use for your first year, but nearly everyone does AIU, the Adopt, Implement, and Upgrade. You are still, if you haven't begun the program yet, you can still do so in the Medicaid world up through 2016. 2014 is the last year to begin participation in the Medicare program. 2014 is also the last year that you're allowed to switch between the two programs, and that is because of how Medicare does not start new incentive programs after 2014. So if you're presently in the Medicaid program and something changes on the eligible professional level, everything in meaningful use is based on individual eligible professionals. If you're in the Medicaid and you want to switch to Medicare, there's time to do that this year. And if you're in the Medicare, you can switch to Medicaid. That's a one-time switch that you're allowed to do. Another thing that happens in the Medicaid programs is that you can be, pediatricians can meet eligibility at a reduced number for 20 to 30% of their encounters are eligible to be billed to Medicaid, as opposed to the 30% or higher threshold that is required for other participants. If you meet it at that reduced number, your incentive amount is also reduced. You receive 2/3. You're eligible then for the 2/3 of the $63,750. That's one of those things that's a little bit hidden, and people receive their first check and see $14,000 and change as opposed to $21,250, and that would be the only reason that should happen is if they met the eligibility as a pediatrician in the 20 to 30%. And payment adjustments. Unfortunately, we, as many of the CMS programs are, there's a few years of incentive followed by a few years of disincentive if you have not adopted this. So this is information that comes from a CMS tip sheet. The link to that tip sheet is at the bottom of the slide. It's about a 6-page. It's a great resource. And in summary, it shows that all eligible professionals must demonstrate meaningful use in 2014 in order to avoid Medicare Part B payment adjustments. I have a couple scenario slides following this that hopefully will help lay out some of the situations. A lot of the messaging is that participants in the Medicaid EHR programs are not subject to the payment adjustments. However, if they are an eligible professional who does qualify for the Medicare incentive program, though they elect to participate in the Medicaid incentive program, they're not exempt from this payment, from this penalty. If they're an MD or a DO who is in the Medi-Cal EHR incentive program, but they have Medicare Part B claims and they're not a meaningful user, they will be subject to the payment adjustment. If you've been a meaningful user in 2011 or 2012, you must demonstrate meaningful use in 2013 to avoid the payment adjustment in 2015. And this is where you still have this tail period in 2014 to be attesting for 2013 program year. And hopefully some of these next adjustment scenarios will help kind of put this to reality. So an eligible professional works at a public housing primary care health center that bills both Medi-Cal and Medicare. Participating in the Medi-Cal EHR incentive program, and you attested to 90 days for 2013, but you plan to skip in 2014. Will you be subject to a payment adjustment at any time? The outcome is yes. In 2016, looking back at that 2014 year of skipped, their Part B Medicare reimbursements will be assessed a penalty. Scenario 2 is an eligible professional works at a federally qualified health center and also at a PHPC and a private practice. So one of those very dedicated, focused providers who is spread thin across 3 different organizations. They attested to meaningful use in 2012, and fell short, was not able to meet the measures in 2013. So it looks 2 years ahead from 2013, and if that eligible professional has any Part B Medicare claims during the entire calendar year of 2015, they will be assessed the EHR disincentive payment adjustment. FQHCs typically do the billing, and none of it is under the Medicare Part B, so the FQHC does not get that payment adjustment, just claims under that eligible professional's MPI that are their Part B claims that are not billed through an FQHC. Scenario 3, and this is walking through a couple different years, AIU in 2011, meaningful use in 2012. Skip 2013, completes that meaningful use again in 2014, skips 2015. So the outcome is that there is a penalty assessed for 2015 because of skipping 2013. And again in 2017, there's a payment adjustment assessed for having skipped 2015. I actually heard on a CMS webinar this morning that these penalty amounts might be progressing 1% each calendar year. And if I haven't had enough time yet today to validate this, that this 2017 Part B assessment penalty might be 3% here, that the 2% would have been if they were subject to an adjustment in 2016. So it might tick up 1% each year, even though you met it in that year in between and were not subject to an adjustment. This is one of the charts that is in the tip sheet that I had the CMS link to a couple slides ago. So it shows the progression, and it also shows the payment adjustment amounts if they're subject to the ERX payment adjustment, which is a separate, different program. The e-prescribing program, that is not just the core measure, that's part of meaningful use. So it shows, unfortunately, how high these payment adjustments can be that we all want to avoid. Changes to Stage 1 in 2014. So there's definitely a lot of folks out there who are in their first or second year of Stage 1 this calendar year. I already covered the 90-day reporting period. Everyone, regardless as to stage, needs to be using 2014 certified EHR technology. There was, the last count I saw, there was about 130 EHRs that were certified for 2014 standards, compared to over 3,000 that were in the 2011 certifications. I do expect this number to increase, this 135, but it's one of the reasons why it was the 90-day reported period was implemented for this year, in case folks need that time to upgrade or even rip and replace their EHR and get it to a different 2014 certified version. VDT, that's something you'll probably be hearing this year if you have not heard it yet, whether you're in Stage 1 or Stage 2, and it stands for View, Download, and Transmit. There is a new Stage 1 core measure that requires that at least more than 50% of your encounters during the reporting period are provided online access to the patients to view, download, and transmit. So Stage 1 typically has not had this patient engagement requirement or the patient portal per se, but for Stage 1, this is it's a revision of the electronic access rule, and I do believe I have a slide on it coming up, that you do need to be able to at least push out from your EHR more than 50% so that a patient has online access to be able to view, download, and transmit. The requirement for the Stage 1 folks in 2014 is not a certain number of patients have to actually log in or see it or be able to receive that. It's making sure you're able to push it out. Menu exclusions are different in 2014 for Stage 1. If you're still working on a 2013 attestation, which many folks are, you're allowed to have your 5 menu selections and have a couple of them be an exclusion, whereas out of the other 5 that you did not select, you might have been able to meet, but perhaps you didn't meet. So what happens in 2014 with menu exclusions is that if you exclude the measure, you need to keep selecting menu measures to show that either you were able to exclude, I think, at least 4 or more, or that you met the menu measure. So menu measures tighten up a little bit for Stage 1 in 2014. There is a changes to Stage 1 tip sheet on the CMS website that I think there might be a link to at the end, and if not, we'll look for it if we can provide it. And then 2014 CQMs. So that, again, is regardless as to which stage you're in for Stage 1 or Stage 2. And then all the talk for meaningful use this year is primarily focused on Stage 2. So Stage 1, back in the beginning, had 15 core objectives. Stage 1 in 2014 is down to 13 core objectives, and it's always been select 5 out of 10. For Stage 1 2014, it's down to 9 menu measures and 6 clinical quality measures, which has brought us to meaningful use for Stage 1. Stage 2 is 17 core objectives and 3 menu measures. For the core objectives, the thresholds have increased, and there are some exclusions. For the menus, there are minimum thresholds to meet, some exclusions, but as I just discussed, they are more restrictive for both Stage 1 and Stage 2 in 2014. And it's a shorter list. You're required to select 3 out of 6. Clinical quality measures are increasing from a previous 6 to 9, and you need to select from at least 3 of the 6 key healthcare policy domains, which hopefully I can, if I don't have a slide, I'll be able to tell you what those domains are later in the presentation. So that is what makes up Meaningful Use Stage 2. 17 core objectives. You must meet all 17 unless there is an exclusion to a measure. Also for specialists and seeing special populations, meaningful use measures are what they are for all eligible professionals. So if you're a specialist or if you work in a rural environment, or you're doing home health visits, all of those types of things, you still need to be able to meet the measures. Oftentimes you might be better able to meet the exclusions, but the measures are still the same. If a measure does not have an exclusion, then there are no special measures and no special exclusions for different disciplines. For example, dentists, they still see patients, which is the only exclusion to clinical summaries, so they must provide an after visit or a clinical summary to be able to meet meaningful use. There's not a special list of measures for dentists, and it's the same way for all specialists and all different realms of healthcare providers. Stage 2, increased percentages. So here's an example where our computerized provider order entry, known as CPOE, Stage 1, it was more than 30% of unique patients with at least one medication in their med list needed to have a medication order entered using CPOE. Stage 2 not only increases to more than 60%, but it also brings in laboratory and radiology results. So it's definitely a hardier, meatier measure in Stage 2. And some measures that are combined into one measure. So Stage 1 core measure number 6, the maintain active medication list, you still need to maintain that list but it's not its own standalone measure. It is now wrapped into the Stage 2 core measure number 15. And that measure is more than 80% of all unique patients seen by the eligible professional have at least one entry or an indication that the patient has no known medication allergies recorded as structured data. So it's no longer a separate measure, and this measure is incorporated into Stage 2 Summary of Care document at Transitions of Care and Referrals. This is probably the biggest Stage 2 measure, Stage 2 Core 15, Summary of Care and Transitions of Care. There's a Stage 2 Meaningful Use Table of Content available on the CMS website, and it links to each of the individual measures' specification sheets. I use those specification sheets daily. They're great resources, and it's definitely one of the spec sheets that you want to dig into and understand and have at the ready for webinars and whatnot to ask questions of. Stage 2, a lot of it is about patient engagement. So for core measure 7, the patient electronic access, they must have access to their health information online, and patients must send secure messages to their physician, Stage 2, core measure 17. This requires patient action. We actually need the patients to do something so that eligible professionals can meet meaningful use. The first item here, this core measure 7, is where part of that Stage 2 measure is what is now Stage 1 core measure. And a lot of folks reply to it, so that the patient engagement numbers are 5%. That 5% of the patients must access their health information online. They need to view, download, or transmit. That 5% of the patients must send a secure message to their physician. Folks that have essentially a patient portal are blowing the 5% out of the water, and it's working and functioning. There's a lot of challenges and people questioning because of patient populations that don't have access to the internet. They don't have broadband. Language barriers, that's a huge one too. But CMS's response is that's where, during the final rulemaking, they decreased the percentage threshold to 5%, a pretty low number. There's a lot of creative ways that folks are meeting this. They don't need to do it from home. They can do it from a public library. They can do it from a kiosk, which is one computer station set up in perhaps the wait room of your practice, where they have your staff there available to help them log on and send a message or to view their information online. So the rubber hits the road with Stage 2. We need to begin health information exchange. It's embedded into these core measures, and hopefully with such a low threshold, it will not be a barrier to eligible professionals meeting meaningful use. The core measure 7, which is probably the second of the meatiest of the two Stage 2 measures, is provide patients the ability to view online, download, and transmit their health information within 4 business days of the information being made available to the eligible professional. So this is where it needs to be pushed out. And the details of the measure are that 50% of all patients are provided this in a timely online access, and that 5% of them, or more than 5%, during the reporting period actually view, download, or transmit. There's another piece of it, and you need to do it to a third party as well. So this is where the specification sheets on the CMS website are excellent summaries of each individual measure. This one might be 3 pages long, but it's going to give you what feeds to the denominator for your meaningful use number, what counts as the numerator on the specification sheets. And then secure electronic messaging. So new measure. We must use secure electronic messaging to to communicate with patients, and that a message was sent using the electronic messaging function of a certified EHR, which the 2014 certification requirements have to have the capability to be able to do electronic messages within, and it's through a protocol called Direct is typically how folks will be utilizing this, or with their PHRs or their portals is a lot of the ways that you'll be able to do and meet this measure. So what eligible professionals need to be doing, and clinics and organizations throughout the country, is provide education and outreach to their patients to show them how to log in, how to receive a message. Some of them will need emails created. Some of the different EHR vendors require a patient's email address to make that patient's account web-enabled. So there's going to be a lot of what some might consider an obstacle, but there's a lot of different milestones to be able to hit and meet to be able to meet this measure. But hopefully the work that's been building through stage 1 will have us be able to succeed in meeting these measures that require the exchange of health information electronically. On to the menu measures for stage 2. So we're down to 6, and we must select 3. A lot of folks are very used to the fact that stage 1 had the requirement of reporting on 1 of 2 public health measures. The immunization registry is now a core measure in stage 2, so you won't really find the requirement for public health reporting in stage 2 because the immunization registry is now a core measure, and syndromic surveillance is still a menu measure. Menu 2 should be one that's pretty easy for people to be able to select and meet. Record electronic notes in patient records. Imaging results accessible through the certified EHR. Number 4, record patient family health history. That should be another one that's pretty fairly easily met, and I bet you a lot of people are doing it with the way they're using their EHRs and their templates currently. 5 is report to a cancer registry, and number 6 is the opportunity to report to a specialized registry, and that would get more into the different niches and different healthcare that a practice offers, and that's where your syndromic registry would not count your immunization, nor would the cancer registry. It would need to be something other and different. It's intentionally not specific in the stage 2 final rule for a definition of a specialized registry. The 2014 clinical quality measures that are required for either stage 1 or stage 2. So the list is expanded from 38 clinical quality measures to 64 of them, and you must select at least 3 of the 6 policy domains, and those domains are patient and family engagement, patient safety, care coordination, population and public health, efficient use of healthcare resources, and clinical processes. CMS does have published recommended suggestions for adult and pediatric populations, which can be found on the CMS website. On the EHR incentive program, they do have a separate, on the left side toolbar, selection for the whole category of clinical quality measures. Electronic reporting of your CQMs is required for Medicare EHR incentive program eligible professionals who are beyond their first year of meaningful use. So if 2014 is someone's first year in the EHR incentive program for Medicare, you do not need to electronically report your CQMs. The state Medicaid systems do not have this requirement of having to report your CQMs electronically. You can report them through attestation, through PQRS, which has its own reporting period. So if you select to report your CQMs through PQRS, it'll most likely be for a full calendar year as opposed to a quarter. That's okay. The CQMs would then not have to match the same 90-day reporting period. And the third option is through group reporting options. So next steps you might be like, wow, a lot of information. It's 2014. What do I need to do? You definitely need to have and be utilizing 2014 certified EHR to be able to demonstrate meaningful use, whether you're in stage 1 or stage 2 for this year. And you have the 90-day reporting period. If you're not ready for it now with 2014 certified EHR, you can get ready. There's been a lot of questions I've seen where folks have said, well, my EHR is not certified yet, but my vendor says they will be. Can I still be using January through March as my reporting period? The answer is essentially yes if they do get that certification by the end of March, but if they don't, and that's you won't be able to use it. You need 2014 certified EHR. Patient portal. See if you have somewhere and the capability to push out from your EHR for stage 1, and you need to be able to have the patient engagement portion working for at least 5% of your patients seen during the reporting period in 2014. And patient portal is probably the easiest way to get there. There's a couple other solutions, and that gets a little bit more into the technology side of the house than I'm experienced with. And educate your patients, encourage them to embrace and understand that you're meeting meaningful use. Some of the media out there is that you use it to upcode. Generally, that's not what's happening. It's pulling together practice management systems, educate your patients as to why you're recording in the laptop instead of a paper chart, that there's federal mandates and payment adjustments, that if you're not a meaningful user, and have their engagement, that reimbursements are decreased. Here's some links to the Stage 2 resources. The Stage 2 guide for eligible professionals is excellent. If I remember correctly, it's about 60-some pages, but as we're all getting smarter and wiser as we move through these years of meaningful use, this guide actually definitely exhibits some of what they've learned through Stage 1, and it's a great resource. There's a Stage 2 toolkit on the CMS website, which hopefully covers everything that you need to know, and within there would be 2014 certification, and then 2014 clinical quality measures. So a link to those, and that's where it would break down the different domains and the information and the lists of what are in there for your clinical quality measures. And that's the end of my presentation, which gives us a few minutes for questions and answers if we have any of those.
Thank you so much, Deanne, for this wealth of information. I know it is a lot for health centers to take in, but luckily we will be sending out the presentations to all of our attendees along with the link for the actual webinar video. So you get the audio and the video, and you also will just get a separate file of just the slides. It also will be made available on our website at www.nchph.org. While we are waiting for some of the questions to form in the queue, I just have a few announcements to make. Here are additional resources, some from HRSA, two from CMS. Deanne already presented some of the CMS resources that you can use directly from her presentation. Also, please visit our website for additional resources on health issues, provider and resident-centered fact sheets, monographs. We also do other free forms of training and technical assistance through our annual symposium, one-on-one training, and additional support for health centers and healthcare providers. I would also like to announce the 2014 Health Center and Public Housing National Symposium that will be held in Alexandria, Virginia, June 10th through 12th. Please see the link to register or to gain more information about that excellent training opportunity for health centers. Also, please feel free to contact anybody at the National Center for Health and Public Housing. All of us are open to questions and any type of issues that health centers may have. We will try to assist you in the best way possible. Please contact us directly. We'll go ahead and open up some of the Q&A. So our first question, Deanne, is for EPs who attested in 2013 for a 90-day period, do they have a whole year or just 90 days in 2014?
They have just 90 days in 2014, so that's one of the perks of this calendar year.
Okay. And also, can providers bill for non-face-to-face contact with patients through the patient portal?
I do not know. I think so, but I'm not sure.
Okay. So we may need to check on that and then get back to the person that asked that question.
Yeah, it's not like Meaningful Use has actually done quite an excellent job of keeping what happens in billing separate from what meets a meaningful use measure.
Okay. Okay. Also, for EPs who attest in 2014 for 365 days in 2013, what period do they attest to in 2014?
Do we know if they are in the Medicaid program or Medicare?
Okay. Well,
I can say both. I can say both. Okay. So the 2013 was 365 days, so it was their second year. So 2014 is 90 days, and if it's the Medicare program, it has to be tied to a calendar quarter. So January through March, April 1st through June, July 1st through September 30th, or October 1st through December 31st. That's in the Medicare program. And if they're in the Medicaid program, they should be able to do any 90 days, consecutive 90 days in 2014, but they do want to check with their state Medicaid program to make sure they don't have the calendar quarter requirement.
Okay, great, thank you. Also, two questions kind of combined together. Can you participate in both Medicare and Medicaid incentive programs, and how often or how common is it for health centers to switch, or healthcare providers, I guess, to switch between the two programs?
My understanding is no, you cannot participate in both. If you're an eligible hospital, I think the answer is different, but as eligible professionals, you need to select one, the Medicaid or the Medicare EHR incentive program. And it's probably not common, but it's not a red flag. You are allowed. I have heard of a small percent of the providers. My organization has been working with over 6,000 providers, and probably 1 to 3, it's not very many, 1% might have the business need or the reason to switch between programs. There's no way that you can switch. One of the rules of switching programs is that your total incentive earned over the 5 or 6 years can never exceed that $63,000. So I think there's kind of one scenario where an eligible professional could switch if they were an early adopter and they switched in one of the first 2 years or so. When you do the math of the incentives you could earn, might have come out a little above the 63, and they just max it out and say no. That's gaming the system. You can't do that.
Yeah. No, I completely understand. Is dental excluded from providing clinical summaries for the changes in 2014?
No, dentists are not excluded from clinical summaries in 2014.
Okay. Also, have you heard of any system where the different government agencies will have one reporting system for health centers to use that they all will kind of glean information from, instead of these separate reporting systems for like CMS, HRSA, and all the other organizations?
No, I have not heard. CMS is working hard at trying to align their various programs, patient-centered medical home, HRSA, PQRS, ERX, meaningful use, but to date I think they're all still functioning and operating out there a bit separately. So they are trying to align.
Yeah, okay, thank you. Have you conducted any research on the challenges health centers face with achieving meaningful use?
I have not. Probably, though, from my work, it's trying to help eligible professionals meet meaningful use. One of the most common barriers is language. You know, resistance to providing a clinical summary in a language that is not the patient's preferred. But no.
Okay. So speaking of barriers and challenges then, how much information do you have to provide to substantiate your claim that you are qualified for an exclusion from one of the measures?
That's a great question. So you exclude for, say, immunizations that you prescribed less than 100. You need to be able to document to an auditor. CMS uses a third-party organization. Their name is Figliozzi and Company. You need to be able to show them some sort of documentation how or why an eligible professional excluded, and have that. At the time that you're attesting, you have all of your answers and you know it. That's the time to build your audit file. If you don't already have one going through during your reporting period, make sure you have something that speaks to every question asked. One of the current stage 1 menu measures is generate a patient list based upon a diagnosis. Know what that patient list was, when it was run, what the condition that you ran it on was, and hopefully have a saved PDF, or if you need to, a printout of that. Because an auditor, that's a yes-no attestation. Did you do this? Did you not? But if you're called for an audit, they're going to say, show me that you did this. And there are, I actually oftentimes will just go to Google, and I don't know that it was listed as a resource, but if you Google CMS audit documentation, you should pretty quickly be able to find a link to a CMS guidance tip sheet on what they are looking for. And generally speaking, the Medicaid programs are mirroring the audit program that CMS started in October of 2012.
Okay. Also, moving kind of further with this auditing issue, what 3 enabled screenshots are needed for auditing purposes?
Core measure drug interaction. It's drug-drug and drug interaction. And then clinical decision support rule, a screenshot showing that one was enabled and turned on. And then stage 1 menu measure 1 is drug formularies. So those are the 3 measures from stage 1, and I don't even know if it's 3 of them in stage 2. It might only be 2 of them where the screenshot. The CMS guideline that I just referenced says at least one screenshot. If you're doing a 90-day reporting period, my advice is try to capture a screenshot the first day of your reporting period, 1 month in, 2 months in, and then at the end of the 90 days. So you just have more. It's going to be better. Even though you can rely on their guidance sheet that says at least one. The other thing is if you're EHR, if they're a good vendor, they should have an audit log within your EHR, and then you don't need any screenshots. If you can show that clinical decision support rule was enabled and that their audit log within the programming of the EHR shows that it was never disabled, that's the surefire thing. A screenshot you could take each morning and then go and turn your rule off. And then screenshot again the next morning that here it is turned on, and then turn it off for your clinical day because it gets in your way. Whereas an audit report would show the programming that it was not turned off every day.
Oh, that's really good advice. Also with EHRs, are there systems or are there EHRs out there that kind of combine the patient portal and the EHR, or are they kind of sold separately or two separate entities?
That's a great question too. A lot of the 2014 certified base EHR, oddly, I do not think requires that it has a portal. So it's probably an add-on at an additional cost. Stage 2 or the 2014 certification requirements for the EHRs is that there's more transparency in what you get with your EHR and at what cost. And the ONC website, the Office of the National Coordinator who oversees the certification of EHRs, that's another Google tip is ONC space CHPL, and that'll take you to that website which shows you can even click on a list that says give me all the criteria that's required in a base EHR, and anything that does not have a red asterisk on that list can come at an additional cost.
Okay, great. Thank you for that. And for our last question, if you participate in the Medicaid program, will participation in the Medicaid program suffice for Medicare?
It would suffice so that you're not subject to a payment adjustment, yes.
Okay. All right. Sorry. I think we have one more question in the queue. Please speak to the role of local public health agencies and state health departments as it relates to fostering the patient engagement requirement in both the Medicare and Medicaid programs.
Well, I'm not sure how they are taking a role in the patient engagement part. We need them for these registries, for the immunization, for syndromic surveillance, cancer registries. That's what I know that we need the local health departments in. Could they play a role in helping to have patients embrace and engage health information exchange? They certainly could, but I don't know that there's a requirement for them to do so.
Okay. Great. Well, once again, I just want to thank you so much, Deanne, for joining us for this webinar, for presenting a lot of information for us to go and take back and really start to change our EHRs, figure some things out, and begin to plan to achieve meaningful use in all these different measures that are required in 2014. So with that, I'll say thanks and have a good day, everybody. Thank you for joining us today.
Thanks for having me.
All right, bye.